Welcome to Echo Autism in Applied Behavior Analysis. It's exciting to see everybody here today, and we have two individuals that are joining us today. Dr. Soul will be joining us for her didactic presentation on common medical and psychiatric comorbidities in children with autism. And then we also have our special guest presenter presenting a case for consultation today, Shireen, that's going to be joining us. And we're very excited for the case that she'll be discussing today. So today we have Dr. Soul that will be presenting, and then we'll move into her presentation. So our case presentation. Dr. Soul, do you want to share your screen, or will we be doing that for you today?
I will share my screen, and we'll go from there.
Wonderful.
Hold on, there we go. Okay, can you see it? All set? Okay, great. So very happy to be here with you guys today. As the title says, we're going to be talking about common medical and psychiatric comorbidities in children with autism. So the less scary word for comorbidities is co-occurring conditions. And what I thought we'd do, I'm going to take you through the first section of the talk today, which is medical conditions. We'll kind of see where we are with time and then have an opportunity to answer questions about the medical aspect of things. And then depending on where we are at time-wise, we'll see if we want to continue with psychiatry or save that for the next session. So we'll get started though, first of all. One of the things I wanted to kind of share and kind of think about together is the concept of family-centered care. And so when we think about autism and we think about what autism centers typically do, we're thinking about family-centered care, and you think about comprehensive diagnosis, team-based care, including our ABA therapists and providers, coordination of all of these different parts and pieces that are happening for the family, shared decision-making between the family and the providers. And what that means is it's not a physician dictating to the family what has to happen or whatever, but it's truly a dialogue about next steps and things like that. Also shared decision, or I'm sorry, not shared, but decision support around, so it sounds like your child is struggling with X, Y, and Z. Have you thought about the following options, or just having these conversations where it's truly a partnership. And so I thought this was helpful to kind of frame up this conversation about this concept and about this model of care that many places do, and I'm sure you have probably heard about before, but wanted to kind of set that up for you guys. When you think about autism, of course, we all know about the core deficits around autism, so your social deficits, your language impairments, your repetitive behaviors, but there's so much more to autism than just those core deficits. You may have intellectual disability. You may have many other factors that are contributing to how that child presents and how they behave and how that interacts with the family. And so many times it's difficult to look at a child with autism through a singular lens. And so that's what we're going to talk about today, is how do we broaden our understanding of autism more than just the specific behaviors and the specific quote unquote deficits, if you will, and think broadly about what else affects children with autism. So one of the sayings that we like to say at our center is that we whole care for the whole child. And so it's treating the whole child and not just their behaviors. And I'll explain more about that as we move along. So obviously, as we think about autism and families who have a child with autism, we see so many overlapping infrastructures that intersect with the family. And so we have community, we have the education system, the healthcare setting, the family itself, and then the child in the center, of course. Other medical problems, though, can have a significant impact on a child's quality of life and also on the quality of life for that family. Many times these medical issues go unrecognized, and can contribute to additional behavioral challenges that can impair the ability for that child to benefit from interventions. I'm getting a signal that my internet is unstable, so somebody signal me if I freeze. Okay, I think we're okay though. All right, so the other piece I wanted to share with you, again, before we get really a deep dive into the medical issues themselves, is what does it look like when a child with autism comes for a comprehensive evaluation? So I know we've had other didactics about the evaluation itself from a psychology standpoint or the assessment. But from a medical standpoint, there are a lot of things that children need to have assessed. And I feel pretty strongly about that. I know not every child who gets seen by an autism specialist sees a medical provider. But here are the things that we look at. So we're looking at prenatal history, birth history. So are there things that happened while mom was pregnant? Were there substances? Was there trauma? Was there stress factors that were affecting the growth and development of that unborn child? What about birth history? Were there any issues with poor oxygen levels at birth? Different things like that that could have affected brain development and growth. We look very closely at past medical history, thinking about all these factors that affect a child's growth and development and how those intertwine with what we're seeing from a symptom perspective. Certainly a comprehensive review of systems is an important piece to what we do as well. And so what that means is we basically go through every nook and cranny from head to toe and make sure that we have addressed and assessed all of these different aspects of a child's health for them. Certainly social history is very important, looking at the family dynamics, who's at home, who is the support system for the family. It's important for us to know, if there are stressors in the family, things like that can also be impacting or contributing to developmental issues. Multi-generational family history is always fun, and that basically gives us some insight. We know that autism has a heavy genetic component to it. We know that about 40% or so, give or take which study you look at, of people with autism have a genetic cause. Now, we're not real great yet at being able to identify a specific cause, but we do have some ways to do that. And so when we see a generational family history, or otherwise known as a pedigree, we are able to then make a better assessment of, is this something that could be more likely to be genetic? Are there other things going on besides just autism? So then I'll skip ahead to the physical exam. So this is something that is important, and I do fully believe that all children with autism should see an autism medical specialist. But so you're looking for neurologic findings, and I'm going to explain here in a little bit why that's such an important piece of things. But autism is obviously the number one thing we're thinking about, and for most of us in this profession, but there are many other things that can layer on. You saw the slide that talks about all these different aspects of things that can co-occur, and so neurologic exam is certainly important. And then something called a dysmorphology exam. So that basically means that we know when certain parts of our bodies form in utero. And so, for example, ears are actually a really important piece of the embryologic development. And so when ears take on a different shape or size or so on and on, I could give you a whole didactic about ears someday if you were really fascinated by that. And so ears actually come together at a certain time when the brain is also developing. So there are a lot of things that we can look at that help us to pinpoint what else do we need to think about. Do we need to think about, and by the way, I said ears as an example. We look at all kinds of other stuff too. And so when we are doing these exams, it's helpful for us because then we can start to put the pieces together for families and make sure that we are providing that whole care for that child. So, hold on, I think I might have frozen. Just a minute. Hold on. Okay, there we go. So things to consider what I really want to focus on today, because I know the vast majority of our participants are in the applied behavioral analysis field, which is awesome. So I tried to really put this in the lens of things for you to be thinking about when you're seeing children and you're working with them in the context of their therapy. So some things to consider. Screening for underlying medical issues, and we're going to talk about how the role of a BCBA might be for that. But to give you a little bit of perspective, so about 50 to 80% of children with autism have a sleep problem, and we'll go into more detail shortly. Constipation is a co-occurring condition in about 40 to 60% of children. Seizures in about 10 to 20%. Sometimes some studies report as high as 25%. Hearing issues, feeding issues, pica, which means eating non-food items, and then referring, things to consider are referring for additional evaluation. Other things to consider and to not forget about, which I find a lot of physicians forget. So dental caries or cavities can be hugely impactful on behavior. And so if you've got a really ugly tooth, but no one's actually looked in your mouth, that can be a huge impact on your behavior because it hurts. And so you're not going to have as, you're not going to be as engaging if you're in pain. And we all know that a lot of our kiddos have a hard time expressing that pain. Eczema or severe dry skin can be another thing that can be quite challenging for children with autism. So if any of you have ever had eczema or other things like poison ivy or things like that that cause intense itching, it's very distracting and it's very difficult to perform either in therapy or at school when you have these other issues going on. So staring spells are a type of seizure, which we'll talk about in a little bit. Abuse and neglect is something to certainly keep in mind as well. Certainly children who have had significant trauma, both either through abuse or neglect or actual trauma, like head injury trauma, can have significant developmental changes that impact that child's development and therefore their behavior. And so those are all things for you to just have on the back of your radar as you're working with children to, for example, if you're working with a child and maybe your behavior plan's not going as you thought it was going to go, what else is there? Be thinking about, all right, yes, we can tweak this and we can tweak that, but am I missing something? Should I get some other folks involved? And that's something that we really emphasize here on Echo Autism ABA is this concept of who else can be on this team, if you will. And so do we need to get a pediatrician involved? Do we need to encourage the family to reach out to a different type of professional to evaluate for their dental hygiene, for example? So just some things to consider. So what we're going to go into now is kind of a section where I'm wanting for everyone to think about, so, all right, that's great. We have these kiddos that might have sleep problems or constipation or whatever, but I'm in the home doing a specific kind of therapy around a specific type of behavior, okay? And I get that. But what I want you to think about, what are some questions that you can be thinking if you have an inkling that maybe there's something else going on or maybe you're missing something, here are some questions that you can ask. The way I've set it up is that we'll talk about sleep, then constipation, then seizures, and then diet. And we'll kind of follow a similar format, and then there'll be time for lots of questions if you have them. So some questions that I often ask families to try to elicit an understanding about sleep. So how long does it take your child to fall asleep? Many times we as professionals will say things like, does your child sleep well? Or any problems with sleep? And it's very easy to say yes or no. But when you ask more specific questions, it can be really helpful. Obviously, data. I know everyone probably on the Echo is super data driven, which is great. But we all know that parents don't always think in that data driven way. So some questions to help you drill down faster. How long does it take your child to fall asleep? What we're looking for is for them to fall asleep within about a 30-minute time frame. So if it's longer than that, then we'll talk about that in a minute. Once they fall asleep, do they stay asleep? So that's this big booger of nighttime awakenings. That's like the bane of a lot of us doctors' practices because it's really tough. I don't have any medicines to make you stay asleep. I have lots of strategies and behavioral options to try to help mitigate some of those issues, but certainly a lot of parents want it to stop now when their child's waking up multiple times per night. So those are just certain things that we can think about. But that's something where you all, in partnership with the physician or the nurse practitioner or whomever, may be able to figure something out for that family and give them a linkage to improvement. So then another question is, do they snore? A lot of people assume that snoring is normal. It's not. And so for adults, it can be acceptable. And a lot of people just think, oh, it's snoring, whatever, not a big deal. But for kids, it really isn't. And so when they're snoring, that can have a big impact on their daytime behavior because they're not getting a good enough quality of sleep for them to actually have restorative sleep and as well as kind of an appropriate duration of that deep sleep. So those are things to think about if you're suspecting sleep problems. So some things to look for. I thought this might be helpful for you guys because you may not be attuned. You may be perfectly attuned, but you may not be. So I wanted to share with you some things that we think about just from an observational perspective that you also might think about. So some things to look for sleep issues. Are they falling asleep during your session? Obviously, that's probably a red flag. It could be avoidant behavior. It could be, different things like that, but it might spark you to ask some additional questions of the parents. Are they excessively yawning all throughout your treatment session? Again, you might be really boring, or they might be trying to avoid you and get out of whatever task you're asking of them. But is it a clue to something else that's going on? So itchy, watery eyes or noses, those are some clues, and I'll explain why in a second. Allergic shiners or allergic salute. So I wanted to teach you a little something. So this little boy up in the top corner, he's doing something we call the allergic salute. And so it's when you have a lot of allergies, and so when your nose is itchy, you're constantly going like this. And actually you can develop little lines at the, like right where, I don't think I can, you can't see my pointer, but right where that little line is forming, you can actually develop lines from chronic saluting of your itchy, watery nose. Allergic shiners, like this little baby has down in the corner. Sorry for the black boxes on the eyes, and it's a little creepy. But he has those kind of dark purpley circles. Those are all indications of allergies. And while that may seem like no big deal, that means they are much more likely to snore, which means they're much more likely to have sleep problems. So without going into massive patho-phys for you, these are just some simple things that you can be thinking about. Are they falling asleep? Do they seem excessively tired? Are they having some of these other things that maybe are affecting the outcome of your treatment? And so an important thing for us to kind of consider. Okay. So then with constipation, so that's it for sleep. With constipation, I wanted to think about some questions to ask here. And I know that a lot of you have worked with children with toileting issues, with soiling issues, things like that. But how do you know when it's a major problem? And I also know that you guys are very great about making sure that children have medical clearance before doing behavioral intervention for children who may have toileting or soiling issues. However, some thoughts to think about. So how often does your child have a bowel movement? That's an important question. Not always do parents know the answer to that question, but still it's a helpful thing for you to find out, because if it's once a week, that might be a problem. Does it hurt the child? Sometimes you can just ask the kiddo, does it hurt when you go poop? They usually think it's pretty funny when you say that word. I encourage you to try it. Does the child hold it? So meaning, are they like really not going, and maybe they're very rigid, maybe they have a really maybe they will only go at home or only go in the upstairs half bathroom, or whatever the case may be. Are there skid marks in the underwear? This is an indication that they have constipation. They're holding it, but their body is trying to tell them something different. And then do they have stool accidents? Unfortunately, sometimes kiddos will have what looks, and sorry, this is the gross part of the talk. Sometimes kids will have diarrhea, but it really isn't diarrhea. And we're going to talk about that a little bit more in a second. So when you're thinking about what to look for related to constipation, and this is a big deal. I mean, this can cause significant behavior issues, and it's actually a pretty simple fix in a lot of ways. Sometimes it takes a little bit of time, but certainly if we can get those kiddos' tummies feeling better, they again can benefit more from their therapies with you, and also be thinking about different or not being distracted by their belly pain. So things for you to look for and clues that maybe there's something else going on. And I've seen this honestly in my own clinic time and again, where the behavior has a major escalation. Maybe there's just this huge, sudden shift in a behavior. And when we dig deeper, we realize oh, actually, believe it or not, they have constipation. And when we get that under control, then their behavior goes back towards their baseline, which is good to see. So constipation, this would be tight cheeks or holding behavior. So if you see that while you're in your sessions, that's an important thing to know. So maybe you need to build in breaks. Maybe you need to do all these things that you all are so well versed at. But those are things to think about. When you start to see them squirming in their seats, those are all do you need to go to the bathroom kind of situations. But a lot of our kids will have holding behavior, which then leads to significant constipation. Tooting or gas is also an indication that there might be some constipation trouble going on. So if you're in session and you have this lovely aromatic sense around you, then you might also want to have a conversation with your patients or clients' parents. So accidents, and I wanted to emphasize this because I've seen this so many times where the parents or the therapists are like, no, they can't possibly have constipation. They have, loose stools all the time and they're constantly leaking. Well, that actually is a pretty common sign of constipation. Same thing with urinary accidents. So if a child is starting to have new onset urinary accidents, it's important to rule out constipation. And here's why. So your kidneys sit kind of in the middle of your back and the ureters come down, but they go by the colon. So if your colon is full of poo, then you basically irritate your ureters, which come down to your bladder, and you can have more frequent urinary infections. And actually, if constipation is left untreated, so severe chronic constipation is left untreated, you can have basically kidney failure. So, there are a lot of long-term consequences from untreated chronic constipation. So, there you have it. Another thing that I assume many of you know about, but just in case you didn't, many children with autism, because they have a difficult time communicating their emotions and feelings, and or even sometimes recognizing what isn't feeling right. I've seen many kiddos with constipation who basically push up on whatever's around them, the back of a chair, the side of the table, want their moms to kind of just push on their bellies. Also a good indication that a workup for constipation would be useful. So if you see that and you're sitting in, again, you're doing therapy or you're doing an evaluation of a new patient or a new client, I know y'all call them clients, but that's like impossible for me. So then be looking for those subtle signs of maybe there's something more going on here that we need to look at while we're developing the behavior plan. We had a case on Echo Autism ABA about two or three times ago about fecal smearing and digging. So I wanted just to bring this learning nugget full circle because we do see fecal smearing and digging with constipation. It's not uniform. Not every kid with constipation does the fecal smearing. Not every fecal smearer has constipation, but certainly something to think about and to rule out any of these underlying medical issues that could be affecting that particular unpleasant behavior. Okay. Decreased eating. Also see this very commonly where the kiddo will just stop eating because you all know the physiology of eating and pooping, and so the more you eat, the more you have to go, the more it hurts. So when you see a significant change in some feeding habits, that's another indication that maybe there's something going on and we need to kind of think about those factors. So what I wanted to show you, and sorry for the but visuals are more helpful. This is how this happens. Okay, so am I frozen? No, I'm not frozen. Okay, I keep getting this stinking signal that says you're unstable. So this is how this works. So normal people are over on this side, and essentially, it's just a normal process. But when you have holding behavior and you don't go when your body tells you to go, it stretches the colon and you lose your innervation or the brain gut connection to tell you when to go, which then is what leads to the incontinence, the fecal incontinence, because basically it's just like, dude, I'm coming. And so unfortunately it takes up to 2 years to retrain the bowel to get the nerve signal back, which is all the more reason, the more people we have out there looking for or understanding this impact and interplay between behavior and constipation and also the prevalence of constipation, the more we can avoid this type of issue for families and children because it's not fun. Okay? So I want to move on to seizures, and you'll notice that I'm not talking about treatments because I felt like, and I'm happy to at a different time, but I really wanted to keep this focused on what can you do as ABA therapists and folks in the home to be really on the lookout for these things. And so hopefully this is helpful to give you some questions that you can ask, and then also some things that you can be observant for. So for seizures, asking families, does your child ever stare off into space and you can't get their attention? If they stare off, do they blink? And we're going to, actually I have a couple of video clips built in here in a minute, and so I'll show you what I'm talking about. Are they tired after staring off, or are they having behavior changes? Does the child have erratic behavior or seem tired or out of sorts after an erratic behavior episode? So sometimes seizures are really funny. And so sometimes a child who has really, really erratic, even violent, aggressive behavior may be having a seizure. Now, again, that does not mean that all of our really aggressive kiddos have seizures, but certainly we do see that type of seizure where maybe that child's, everything's going along fairly normally, and then all of a sudden there's just this out of nowhere stark change in their behavior, and sometimes that can be an indication of a seizure, and so it's something for us to just keep an eye on. So some things that you can be looking for. Blank stares or being zoned out, that's a really common one and important to think about. So of course, everybody daydreams. I am notorious for kind of getting lost in my world, but I blink and I will respond to you generally. And so if you're working with a kid and you see them just stare off and you're like, what just happened? That could be a seizure. And when I show you the videos in a minute, you'll see how subtle they can be. Again, abrupt changes in behavior, so be thinking about that. Obviously, you all are knee-deep in behavior and working with these kids on behavior. So, of course, the vast majority of these abrupt behavior changes are not seizures, but it's still something for you to think about. Again, if you're going along with your treatment plan and you realize this isn't working like I think it should be working, then be thinking about other strategies that you can look at. Abrupt crying or shaking. So certainly kiddos that just kind of spontaneously start crying kind of for no particular reason, that actually can be a seizure. So those are things to keep in mind as well. Loss of bowel or bladder control, again, can be a seizure, not as common, but can be indicative of that. Nighttime behavior changes. So this is definitely one that I think is important for you all to know about as you work with families. So some types of seizures only happen at night, like in the middle of the night. And so they're not as common, so they're pretty rare, but they do happen. And so if you have a situation where a child maybe has always been a good sleeper and now all of a sudden they're waking up with these just wild erratic behaviors, or they're, sometimes they will actually have kind of drop spells where they're kind of catatonic, so they don't have any movement at all. Those are also obviously something going on neurologically. Clearly, don't mistake this for a night terror. Many kids in the age ranges that we work with a lot, and I'm sure you work with a lot, have night terrors. And night terrors, those are pretty common and not a big deal. But keep on the back of your radar like, maybe we should check that out, because I would hate for you to be spinning your wheels on behavior plans if there really were seizures that were contributing to those behaviors. Okay? So we're going to look at 2 videos, and let them, there we go. So they're very short. They're only about 45 seconds. The first one is of a little boy. He's about 2-ish. So I'm just going to let you watch that.
Yeah, and say, I want a cookie. You want a cookie? A cookie. Cookie. Hey, dinner. Sweetie. He's poking me in the face. Not having no dinner. What's this? Cookies. Okay.
So I don't know about you, but that's pretty subtle. But the mom is clearly waving in his face. He's not blinking. He's not responding. He is still moving. And you even heard the dad say, he's not having no seizure. He's poking me in the eye with the key. And yes, that's true. Typically, when you're having a seizure, you're not going to have other aspects of movement, but I have seen it before. So you saw how subtle, how short those were. Absent seizures or absence seizures, but the correct way is to say absent, so you sound super cool and smart. They can be incredibly short. So you saw that little boy in that video, very, very short. And so it's important though, because there's still a big impact on the brain as they're having those little tiny short seizures, especially if they're happening multiple times a day. So those are things for us to just kind of have on our radar. If you're working with a child and you see that, that's something for you to think about. This little guy, I do want to show you because his are a little bit more obvious. Again, absent seizures, because that's going to be your most common kind in autism.
Even though you're absent, she sent me the homework that when I was absent. Okay, so what are you supposed to do today?
So I think my take-home message is probably fairly clear. Those are subtle. I don't know how many of you would have seen those. And certainly if you start to notice a pattern of, gosh, this kid just kind of like zones out on me every so often, talk to somebody. Share with the parents, hey, I heard that seizures are more common in kids with autism. I'm not sure what I'm seeing, but I think you should have him see the pediatrician or whatever. I think those are important things for you just to have on your radar because I can guarantee you it will impact your ability to make the outcomes you want with your behavior modifications and your behavior plans. So that's an important thing to keep in mind. Okay, so next, once I can get past this slide, hold on. There we go. All right, so then thinking about diet. So this is the last one. And honestly, I think many of you are very, very well versed in feeding issues, diet, things like that. But I wanted to give you just kind of the sense from the other side, if you will, about how we look at it and how what things we worry about related to diet. So here are some questions you might ask, and you probably already are. But does your child eat something from every food group? So I'm a pretty low threshold kind of person. I let ketchup count as a vegetable, so if that tells you how low threshold I am. Not at my house, it doesn't count, but for my patients because they're so limited. So do they refuse certain textures? Do they follow a special diet? Gluten-free, casein-free, the list could go on. Does your child eat non-food items? And I'm sure all of you have heard, many stories about children with autism and pica. So I can tell you that from my standpoint, pica is really concerning to us, both from a safety standpoint and from a nutritional standpoint. So when I see a child with severe pica or pica in general, there are things that I have to look at to make sure that there's not an underlying medical cause. Some research talks about how iron deficiency can predispose people for pica. So I always make sure that we aren't having iron deficiency anemia kind of issues, leading kids to be eating dirt and whatnot. But more commonly are the kids that eat really scary stuff, staples, tacks, all kinds of different and not good things for you to be eating. And so those are important things for us to know about. Does the child drink milk? So milk is a common form of calcium. It's not the only form of calcium, but we do want to make sure that they have strong and healthy bones because they can't grow without some of those key nutrients. One quick caveat though, back thinking about the constipation, if you know that your particular client drinks a ton of milk, milk and dairy products are your number one cause of constipation. And I've had a lot of success with families just cutting the milk or cheese in half. So if they're drinking 60 ounces of milk a day, which is sadly not that uncommon, cutting it back to 30 ounces of milk a day. A lot of times because our kids don't like change, what we'll do is just add water. So they still get the same volume, but they have half the actual amount of milk. Those are strategies that we've used and has been pretty helpful. But anyway, just again, circling back to diet and constipation, if they're huge dairy eaters, that can be a big deal. So then lastly, does the child get spacey with illness or fasting? This is probably not something that you are going to dig into because this is a little bit, it's pretty specialized. But if you were to ever hear a parent say, they got dehydrated and they were just totally out of it, well, that can give you a clue into an underlying metabolic issue. And so I'm definitely not going to bore you with this part, but all of our bodies are built on biochemistry. And if you're missing some part or piece to your biochemistry pathway that kind of make your body run, then when you don't have food feeding your pathway, if you have one of these metabolic problems, then you can actually go into a coma. And so these are different, and I'm using somewhat of layman's terms, but basically, if you were to ever have a family say to you, gosh, every time they don't eat for 10 or 12 hours, they are just out of it. That would be you should see your doctor. And most of these happen in early childhood, but that is actually not exclusive. So you can have some people who manage to make it to their teenage years with a somewhat significant metabolic problem and still not have been picked up. But they're very serious and you can die. So that's one not to miss. Then lastly, things for you to look for. Again, I know that you're not going to be doing growth charts and things like that, but when they come to the pediatrician's office, that's one of the important pieces that are done at any kind of primary care office is looking at growth over time. So we're literally tracking their height and weight on the growth chart over time, and that helps to inform us on whether they're growing at the appropriate pace or not. If for some reason you happen to be working with a child around feeding, it wouldn't be a bad idea for you to track their height and weight. Parents can do that at home. They can do it on their home scale. And it's certainly an important thing to be thinking about, just because that way you can know, oh man, are they losing weight at a rate that's atypical? And so we don't have time anymore to, we've got to accelerate our behavior change, or we have to accelerate what we're doing for intervention for this child because he's now starting to have weight loss or lack of weight gain, things like that. Other pieces that we look at for lab evaluation, so we do draw blood work on children with autism on a fairly regular basis. That's probably a topic for another time as well, but related to nutrition, vitamin D is very commonly low in our kids with autism. And what we're learning about vitamin D is that there's tons and tons of things that vitamin D does for our bodies. And it doesn't necessarily you don't necessarily get the appropriate amount from the sun. We used to think, oh, you just spend 15 minutes outside and you'll be fine. But what we're actually learning is that's not necessarily the case. So for kiddos that have very limited diets, we often will do a vitamin D. We also often look at protein levels to make sure they're not, that they have an appropriate amount of protein, if you will, in their bodies. Hemoglobin is basically your blood count, making sure the kiddo's not anemic, because if they aren't getting many protein sources, they have a high risk of being anemic, which can lead to a whole myriad of other issues. And then thyroid studies. So if the kiddos are losing weight or not gaining weight, or they're gaining too much weight, then we often will look at thyroid studies as well. Certainly things for you guys to be thinking about. Are there aversion issues, food aversion issues, oral defensiveness, things like that? Is it a sensory piece of things? One of the gals that works in our clinic is a dietitian, and I loved what she said, and you guys, maybe this already makes total sense to you, but kids with autism are so insistent on sameness that no wonder they don't want to eat an apple, because every apple's different. You might have a bruise on one apple and not a bruise on another apple, but every chicken nugget from McDonald's is exactly the same. Every Pop-Tart of whichever variety is exactly the same. There's no variation. And so it lends itself to them having very, very rigid diets and not having as much success with your more variable foods like fruits and vegetables. And so that was kind of an aha moment for me. Maybe you all have already had that aha moment. But certainly I think when you look at it from that lens, it can be helpful. So you can start to explore some different foods that are within that same category. So at this point, I do want to stop because I think we're getting a little bit, I don't actually know because I forgot to check the time, but want to be able to open it up for questions from the participants, and I'm also happy to talk about things that you're interested in.
Perfect. Thank you so much, Dr. Soule. That was an excellent presentation and highlighted exactly what we were hoping to learn from you today. So Dr. Soule, I wanted to ask you really what you were bringing up in terms of the different types of behaviors that we could look for so that we could make a referral. I would recommend you see your pediatrician. Sometimes we've made the referral to see a pediatrician, and we work in often some pretty rural or underserved communities. The parents might go and see their pediatrician, but not necessarily receive information that they feel like the pediatrician maybe was able to effectively treat their child. What would be your recommendations in the sense of what type of information could we provide if we were to say share these specific things that we've seen so that it might highlight what they might want to look for?
Absolutely. So great question. I think that truthfully, we being medical providers, we are pretty data driven. And I would say that if you can show them, so like those things I said to be on the lookout for, those are things to share. Have the family share, like say to the family, okay, listen, I really am worried your child has constipation. Here are the things I've seen, and I think you should see your pediatrician, and share these things with them, because unfortunately, this is kind of a double-edged answer. I think that's the best strategy for you all to be able to say, here's what I've seen, family, take it to the doctor, here's what my therapist has seen. Unfortunately, not every, and probably not even close to a quarter of all primary care providers understand that constipation is very common in children with autism. And they don't understand that sleep problems are very common on autism. In fact, it's very common for me to hear, oh, that's just the autism. And it's not. And so I didn't go into my usual, so I give a similar talk to pediatricians and family docs and nurse practitioners. And so that message to them is, this is common and you treat it the same way you do anybody else. It's not just the autism. I think that's why I say it's kind of double-edged, because while I'm encouraging you to make those connections to the primary care provider, and I want you to, and I think with time and persistence and consistency, that family will be heard because of you. However, I'm keenly aware of the fact that primary care providers don't have a real good working knowledge of autism and all of the factors that go into it. And so I think that's an important thing to know. And so just a quick story, and I promise I won't take very long, but I think it illustrates this pretty well. A patient of mine, mom called our specialty center saying, gave symptoms of pretty extreme constipation. I'll spare you the details. The family lives about an hour and a half from us, and I was very worried that this child was nearing critical. So in other words, you can actually perforate your gut if that's pretty stinking rare. But this kid sounded really serious. Okay, and so I said, they were like, can we just come and see you? And I'm like, I'm an hour and a half from you, and no. And so, so anyway, we got them into their primary care doctor, who's a really good physician. I called ahead. I said, hey, here's what I'm hearing. This is what I'm worried about. I really think they need to have an X-ray to figure out, how bad this is. And unfortunately, when they got there, he decided it was all behavioral and put him on Risperdal. And so they still ended up coming to see me so that I could fix the underlying the underlying GI issue. And so all I can say is that we all are working on this problem from many different angles, meaning you all have that same communication issue. Like, well, I can't get the doctor to listen to me. And so it's really about awareness, and it's about saying like, no, I really think he needs to be looked at, and it's okay if that doctor might take a visit or two to kind of come around. But I do think it's important for you to be aware of the symptoms and then raise that awareness level with the family, who can then raise it with your observations to the pediatrician.
Great. And I guess that also stems very nicely into the 10 replications that you currently have for Echo Autism in primary care across the country.
That's true. That is very true.
I see that we have somebody that raised their hand. Shireen, I'll go ahead and unmute you so that you can ask your question.
Okay, can you hear me?
I sure can.
Okay, so I think that the presentation was phenomenal. It kind of ties into what I'm going to present today. But as regards to the pediatricians, we find it very common that it's not the pediatrician that's actually diagnosing the children with autism. They're being referred to neurologists and then to ABA centers for treatment. So then we'll make referrals back to the pediatrician. For example, I got a kid I think needs some GI testing. They always question our qualifications and our credentials, and they are not always in agreement with us 100%. How can we go about getting pediatricians more on board?
Yep. So I think that's a great question. So you're right. So pediatricians in general do not diagnose autism, generally speaking. But they do take care of plenty of kids with autism. Typically, the diagnosis is made in specialty centers by a specialist. So whether that's developmental behavioral peds or child neurology or child psychiatry or child psychology or neuropsychology, on and on and on, right? So, but it's usually made by a specialist. So I think the tricky piece is it's that trust factor, right? So, I mean, it comes down to, well, I don't know who you are and you don't know who I am. And it's that dynamic. So, and when I say trust factor, I mean between you, Shireen, and one of your patients' pediatricians, and between that pediatrician and the neurologist. Maybe they are like, that neurologist has no idea what he's talking about. He diagnoses everybody with autism, or vice versa. And so the way that we are trying to go to get past that is by having a standard of evaluation. And so I work with an organization called the Autism Treatment Network, and we have we've been together. Well, it's a national network. So there are 12 sites across Canada and the U.S. And essentially, we are trying to work with that Joe Schmo neurologist who maybe isn't following best practice and is just kind of like waving a magic wand and trying to decide by looking at the kid if they have autism, which for many years was the way it was done. So for many years, in case you don't know this, not just you, Serene, but everybody, a kiddo would go into a neurologist's office or a psychiatrist's office, spend 20 minutes maybe. Maybe if you were lucky, you'd get an hour, but it was mostly just parent history and like brief observations, and then leave with or without a diagnosis. And we now know that that doesn't cut it. So you've got to have, you have to have structured behavioral observation. You have to have clinical expertise in that to weigh in on that diagnosis, and then also parent report. So anyway, the whole point of that is to say it is kind of this trust factor and trying to figure out, well, okay, how can we get the pediatrician to be working with somebody that they do see eye to eye with? And then what I usually default to is, okay, who really cares? This kid clearly needs help. So I don't know if he does or doesn't, and I don't really care if you think he does or doesn't, but this child needs help. And so if it's about constipation or sleep or ADHD or whatever, then I always find it pretty useful to bring it back and say, gosh, I'm really sorry that it sounds like there's some conflict there. My priority is to help this little guy with fill in the blank behavior. And I'm worried he may have constipation or sleep problems or seizures or whatever. Sorry.
Yeah. Excellent recommendation, and thank you so much. I think that I personally am walking away with some additional knowledge about what to look for to be able to make appropriate referrals and recommendations. So thank you for that just wonderful presentation. And I believe then for our next clinic, you'll be covering psychiatric comorbidities as well. So we are looking forward to that follow-up part 2.
Great.
So Shireen, I'm sorry?
I'm going to stop sharing.
Super.
There you go.
Perfect. And then Haley, if you would like to go ahead and put Shireen's case presentation on the screen. Shireen, we are ready to begin the next portion in which you'll present your case. So the first piece will be about 5 to 7 minutes for you to review the case. And then if you don't get through all the information, that's okay, because the next step is that we'll actually go through clarifying questions. That will be the opportunity for the other participants as well as the panelists to ask additional questions about the case, and then we'll move into recommendations from there. So whenever you are ready, it looks like your case is up. Haley, do you mind enlarging the text a little bit, zooming in? Thank you. And I will go ahead and take your mute off for you as well, Shireen.
Okay, I'm here.
Okay.
Okay, I was like, it looks a little awkward on the screen. Okay, so I know the doctor is going to have a lot of insight on this, and I'm so looking forward to it. So I have a 4-year-old, 4-month-old, 4-year, for your 4-month client who I've been working with, and the primary concern right now is sleep patterns. Per the parents' report, the kid is going to bed. They're getting him ready for bed about 7:30 in the evening, and he's not falling asleep until 9:30. And when he goes to bed at 9:30, he's back up around 2:30, and he's staying up until it's time for him to go to bed again later that evening. Throughout the day, he has ABA therapy Monday through Friday from 8 to 12, and then he goes to after school, preschool from 12:45 to 3:30. When he gets home from school, goes on a walk, do some structured activity, they have dinner, and then it's back to the bedtime routine. On the weekends, the schedule is pretty much the same as far as his sleep, but no structured activities throughout the day. It's pretty much go with the flow. Part of the problem that the father is reporting that mom sleeps with the client and she doesn't sleep in the bed with him, and that the child will not go to sleep initially unless mom is there. They also reported that when he is asleep, he's not comfortable unless his head is positioned in between the bed and the headboard. So when I got the report from the parents, I suggested that they talk to an occupational therapist for the purposes of his head between the headboard. Probably the need for pressure is there. Functionally, this child, he taken the VB map, and he's almost scored out of the VB map. He's high level 3, and we're going into the ABLS to work on more functional skills as far as his ability to comprehend and to understand a procedure we put in place. There's a picture schedule, get it ready for bed. We put a time, what time he's supposed to go to sleep, what time he's supposed to wake up. We've done a lot of activities before bed, like reading a book, making bath time longer. We've even worked on extending bedtime from 7:30 to getting him in the bed at 9, and hopefully he'll be asleep by 9:30. We also asked that dad start working on the bedtime routine and not have mom do it, because he seems to have a real strong attachment to mom. This is not just during bedtime, but also when it's time to leave for school. Mom was in school, so when mom leaves out the house and it's time for ABA, we have about 45 minutes of tantruming before we can actually get him into the treatment setting. So that's pretty much it.
All right, thank you so much, Shireen, for that case summary. I'm going to go ahead and briefly just summarize in a couple quick sentences, and then we will move on to questions from our audience and panelists. So we have a 4-year-old diagnosed with autism that's receiving ABA therapy for approximately 20 hours per week. One of the primary areas of concern right now for the family is concerning his sleep. He's having difficulty with sleep onset as well as nighttime awakenings. And it seems that the primary parental figure that is assisting him with his nighttime routines is his mother. And so you have been working with the family, and I apologize, I don't know the duration in which you've been working with the family, but that will be one of the questions that we'll get into. But you've been working with the family to establish some behavioral strategies to assist with the nighttime routines. So you are here today to learn some additional strategies that maybe could be put in place, especially for the nighttime awakenings as well. Did that summarize the areas of concern and what you're looking for today?
Yes, ma'am.
Okay, super. All right, so then let's go ahead and first open it up to our participants in the audience to ask some additional clarifying questions. If you like, you can go ahead and just unmute yourself at this time.
Hi, I had a question, but I couldn't catch my mouse.
I saw that. It's giving you time. Oh, it looks like she's frozen. Okay, I think maybe what we'll do is give Sarah a minute to see if her internet connection restabilizes. In the meantime, is there anybody else in the audience that would like to ask Shireen a clarifying question?
I have a couple questions.
Great.
My first question is, when you pushed bedtime back to 9 o'clock, did it still stay at the 2-hour window before he fell asleep?
Oh, let me go ahead and unmute her really quickly.
Okay.
Can you hear me?
We can hear you now, Shereen.
Okay, so we started the 9 o'clock bedtime routine this week. I was out to the house on Tuesday morning, and when I got there about 9:15 in the morning, because session is from 8 to 12, he had not been asleep yet. He had been up since 2:30 again. He went to sleep about 11:45 and was up at 2:30. So we're still in this hour and a half, 2-hour time frame, and he's still waking up at 2:30 every night, every morning.
Okay. And my second question is, what does his behavior look like when he's awake? Is he tantruming, or is he playing, and how are the parents? Are they engaging in play with him?
So when he first wakes up at 2:30, I had advised them not to even go into the room, to place a baby monitor in the room to make sure that he's okay. As long as he's not engaging in any type of playing, anything that's going to stimulate him to encourage him to stay awake, don't mess with him. He's just laying there and you know he's awake, leave him. But they've noticed that he'll stay in the bed for about 30 minutes. And after that, he'll get up, he'll turn the light on, he'll read a book, he'll start responding to himself, he'll get up and pace the hallway so he can come in the room, or he'll go wake his baby brother. And from there, they say he runs through the house all night, he cries, he asks for stuff to eat, stuff to drink. It's just like, well, it's time to wake up, let's start my day.
Okay, great. Thank you for that information.
Great. Thank you, Kate. Those were really great questions. Sarah, I see that you're back on. Would you like to give it a whirl?
Actually, Kate asked the questions I wanted to, so thank you, Kate, and sorry about my internet being unstable.
Yeah, no, not a problem at all. So that supports what great questions they were, Kate. I love that you contributed. Thank you. Okay, so then we'll go ahead and move on to clarifying questions from our panelists, and then into some opportunities for recommendations. I'm going to just ask a couple of clarifying questions about his routine and the conditions of the environment when he's sleeping, and try to leave some other areas for other panelists as well. Shereen, would you mind sharing a little bit about what his routine looks like at night, and when he is going to sleep in his room, what the condition of the room is in terms of, do they have any sleep machines, night light, and things of that nature to help with the comfort level when he goes to sleep?
So if for one thing to understand about this case is English is not their first language. He's the first American, first person in family to be born here in the United States. So they're still used to their customs back at home from their country that they're from. So in the household, it's him, both his parents and his grandparents and new baby brother. So they have a really strict routine of sitting down and eating together as a family, which is about 5:30, 6 o'clock in the afternoon. And after that, he's allowed to watch TV, play with the iPad, read a book, do something by himself. This time from after dinner until bedtime routine is the only time he has throughout the day, during Monday through Friday. He has time to be by himself, not structured. So at 7:30 is when bedtime routine starts, and it starts with the bath. From the bath, it's then he has a snack, and then he's put to bed. His snack consists of warm milk and possibly a cookie or some goldfish.
Okay.
And so they'll put him in a room and tell him it's bedtime. They'll turn off the light, close the door. He has no night light. He has no TV. He has nothing in his room that you would think would be stimulating, except books. So we know from the baby monitor that when he is left alone in the room by himself, he actually climbs the bookshelves and pulls all the books off. So for safety, I've asked the family to take the bookshelves out of the room and just only leave the bed in the room. So that's been done. And still with that, he's still getting up and responding, speaking to himself, walking around the room, playing, jumping off the bed, or coming out of the room and wandering the house.
Okay, excellent. Well, I can tell that you've already put a lot of time and thought working with the family, and part of the reason why I was asking the question was to determine a little bit more about what he had access to, the conditions in which the room was set up, even when he wakes up in the middle of the night. So was it different when he goes to sleep versus in the middle of the night, and what he would have access to? And it sounds as though you've been already providing recommendations to the family to minimize those activities and keep the environment consistent. So that's wonderful to hear, Shireen. I actually want to also pass it along to maybe Zoe at this time, because you had mentioned some of the other family members in the home and some of the cultural pieces, and so I thought maybe she would have some questions around these areas as well.
Great, thank you, Joy. So I'm Zoe Miguel. I'm a licensed clinical social worker, and so sometimes I come to these questions with a little bit of a different lens. And thank you so much for the presentation, Shireen. It's I think it's very appropriate given that we were just talking about sleeping issues, so it's great. I had a couple history questions. So has sleeping always been a challenge for this little guy?
Yes.
So since he was a baby, he's never been a good sleeper?
He's always slept with mom, which I identify as one of the concerns that that's where the attachment comes from, always being under mom. And it's not just during sleep time, it's throughout the day. Mom, since he's old enough to go to school now, has went back to school herself to pursue her career. And whenever she leaves the house, even if we're not in ABA, dad reports or grandmother reports that his behaviors are to the point that they don't know how to handle him. So I know that mom is a primary factor now, and I'm working with mom on letting go somewhat too.
Is that, and again, just not going into any specifically identifying information, but is that culturally pretty appropriate and appropriate in sort of the norm that the child would be co-sleeping and doing most of the things during the day with mom?
Well, I think some of it is cultural, and some of it is a learning opportunity, because since they had the new baby who just recently turned 1, dad refused to allow mom to sleep with the baby. He said, this child does not have autism, and I don't believe that the first child's sleep issues is all related to the autism. He strongly believes that mom brought on some of these problems by always wanting him to sleep with them. So he does not allow the new baby to sleep in the bed with them, and he sleeps fine.
Okay.
As far as what I've observed when other family has come from out of town, as far as cultural aspects, I did observe the aunt feeding the 10-year-old nephew who is typical development.
Okay. And then when was the baby born?
The baby just turned 1 in May.
Okay. And has there been significant behavioral changes since the baby was born?
Actually, since the baby's been born, he's been more calmer, because when we knew mom was pregnant and when she was obviously pregnant, we put in a plan to help him be more conscious of a baby in mama's belly. We brought in a doll and taught him how to nurture the baby, welcome the baby. So he was okay with the baby coming. We do try to make him more aware, like acknowledge that he has a brother. We have him going to help mom and dad out, like giving him that big brother role. So as far as behaviors in a way of helping, it's definitely increased. He's actually, when the baby is around, he's more mild tone. Whenever the baby is not around, he's more aggressive.
Two other quick questions. Is mom sleeping with him in his room, or is he in bed with mom in their room?
No, she's sleeping in his room.
Okay, great. So he's in her room. And when that time period between his sort of free time, is he mostly on the iPad or the television?
Now that I am not exactly for sure, because
Okay.
I've asked parents. I actually asked them to increase his downtime. To increase his downtime.
Okay.
Because he's have too many structured activities throughout the day. So I know that mom says she does not like the iPad because she don't want him to become overly obsessed with it. But
Yeah.
it's the same thing with the television. The television could just be on. He doesn't have to be in the same room with it. It just has to be on.
Okay. And that's just during his free time.
Just only during his free time.
All right, great. Thank you so much for those clarifying answers. I appreciate it.
Thank you. You're doing an excellent job sharing, providing us with information. I'm very impressed. Tina, Dr. Goldsmith, would you like to go next with additional clarifying questions? Unmute you. Okay.
Hi there. Again, I'm Tina Goldsmith. I'm a psychologist and a board-certified behavioralist. So I have a few questions. I guess one of the things I was wondering is, does he talk about his sleep? You said that he was a higher functioning kiddo, and I'm just wondering if his verbal skills support him being able to talk to him about sleep, and if he has things to say about him staying up late or waking up in the middle of the night.
His verbal skills are not up to par with all his other skills. When he verbalizes, most often it's one or two words. If you ask him if he's sleepy, he'll say yes or no. Or if he's just really, really tired, like again, ABA is from 8 to 12, Monday through Friday, he'll say, sleep time. So that's his way of asking to take a nap or to lay down.
Gotcha. Okay. And then with regard to data collection, I'm wondering, it sounds like your recommendations have been great so far. I think you've tried a lot of amazing things, so kudos for that. I think one of the things that's hard is not just about coming up with the right recommendations, but about ensuring that folks are adhering to those recommendations. And when it comes to things like sleep and eating and toileting, parental adherence to treatment recommendations can be hard. So I'm just wondering if you're having them take data. Have they been completing a sleep diary? Have you been using the sleep diary as baseline data to inform some of your treatment decisions, such as that sort of nighttime restriction for sleep? How has the data collection been going, especially as it relates to treatment adherence?
So we're in the second phase of it. The first 2 weeks, all I wanted to know was yes or no if he woke up throughout the night, and yes or no if mom slept with him. So what we got from that data was I asked for at least 10 days of data. Out of the 10 days, he did not sleep none throughout the nights. The nights, and when I say sleep throughout the night, I mean from 9:30 when they say he usually go to sleep to 6 o'clock in the morning when they say he would wake up normally. On the 10 days, he had not slept from 9:30 to 6 a.m. And of those 10 days, 5 of those days, mom got up and got out of the bed after she could not get him to sleep because she had to go to school herself in the morning. So they just let him roam. So the data didn't show really anything consistent other than the fact that he did not sleep. It didn't matter if mom stayed with him or she didn't stay with him.
Gotcha. And you described, and maybe I misheard, 2 phases. And so are you now that you've got...
The second phase is...
Sorry, go ahead.
Okay, I'm sorry. So the second phase, we've now determined that, yes, mom may have been a factor, may not be a factor, but because his behavior did not change, whether mom was in the room or not, we're just not having mom go in there at all. We're removing mom completely. We're now having dad do the bedtime routine because, again, of the attachment to mom. So dad's procedure is to take him to room, to put him to bed, and to leave. And if he tries to come out the room, just to redirect him back to the room. There's nothing in the room anymore. It's just the bed and him.
Gotcha. Okay. And it sounds like, I think it was great for you to start with pretty low expectations with regards to parents taking data, right? Couple questions, yes, no, and now that you've seen that they've been willing to go along with taking data and they've done a good job with it, do you think you could kind of build on that, that compliance and have them actually complete a sleep diary so that you're getting some more detailed information to kind of refine some of the recs that you've already got in place?
I actually did, because like at our company, we work on teams. So I am on a team of 5 other people plus a lead and a regional director. So we've all come up with this sleep diary that we want to implement, and they've actually come out to the case and did their own observations just to see, where else could we improve. And although the parents are compliant at this moment, due to the parent scheduling, because Dad is an ER doctor throughout the night. So not every night, but some nights that he's there, it wouldn't be consistent.
I see. So you're saying that, so sorry, I just want to make sure I understand this. So Dad's an ER doc, so he sometimes is there, but sometimes isn't there. So that's introducing some inconsistency in his ability to support the nighttime routine and also his ability to support data collection as it relates to sleep. Is that right?
Yeah, so we're asking that on the nights that he is home, that he actually completes the bedtime routine.
Gotcha. And just a follow-up question related to that real quick. Is it, some of what you're describing is making me wonder if there are some natural disturbances in the home. So is Dad on call such that he's getting up and there's activity at the home at night, or is he coming in and out of the house at night? Is the newborn baby now 1 year old sort of still waking up at night? Is mom getting up to breastfeed at night? So I'm just wondering if nighttime really is a time at home where everybody is down and quiet and sleeping, or these factors with Dad possibly being a nighttime ER doc, baby at home, grandparents around. Is there activity that could be influencing his sleep schedule?
Oh, that's a really good question. And just from what I know, just based off conversations with the family and being there for so long, Dad works 3 days a week. So he's only gone throughout the night 3 days a week, the same 3 days every week. The baby sleeps in a room with mom and dad in his own crib, and mom stopped breastfeeding at 4 months.
Okay. Gotcha. All right, last question. I'm going to pass this one out. Is there any shift from weekday nights to weekend nights such that they are perhaps sticking to the plan a little bit more carefully during the week but loosening things up on the weekend? Or do you find that they're at least within a reasonable way trying to adhere to your recommendations consistently Sunday to weekend?
Okay, so Dad's schedule is Sunday, Monday, Tuesday night. Okay, so this kid is 4 years old. He's been in therapy since he's been 2.5, and he's been 20 hours of therapy consistently in addition to speech, OT, and school. So I asked that on the weekends, let him have a time to be a kid, go outside, play. I've actually put some social activities in there. What my goal with the family was to take this weekend to try to tire him out throughout the day. And we can stay consistent with, if not so structured, but having him active, we could continue with the nighttime routine on the weekend. And they've just got to the point where they're comfortable allowing him going out in the yard. So again, I think like a lot of this is the cultural thing, because we have another family who said, well, we could go back to our country where kids go out and play all day and we wouldn't have these type of problems. Whereas when they're here, they're restricting what they're allowing their child to have access to. And that's also been a problem within therapy. It's got to the point where Dad is so tired and depleted of energy because he's not sleeping. He's now willing to be more compliant to the treatment recommendations for the sleep test. The sleep assessment.
Gotcha. Thank you so much for answering my question. Really appreciate it. And I'm going to pass it to someone else.
Great. I think, Kathleen, you had a question, and then Dr. Stoll, I know you have some really great questions that are going to be coming up too.
Hi, Shireen. It's Kathleen. I'm really glad you mentioned physical activity. I was actually going to ask about that myself. So my only other question would be, it looks like on the case presentation form you've checked off that you are coordinating care with the child's primary care physician. So I was just hoping you could elaborate on that a bit and share specifically if you're coordinating care regarding this concern and what input the pediatrician has had.
So I put coordinated care because 2 weeks ago, Dad and I had a conversation about his role in the sleep process. And he said, well, I would like for you to come to the doctor and talk to the doctor and see if the doctor can recommend anything for us. So I've got as far as signing the consent to share my reports. I'm waiting for the doctor to agree to it and have me to follow up with his next doctor's appointment. Dad has now started giving him melatonin and is going to start giving him Benadryl to make him sleep. And I said, well, I'm going to write in my treatment recommendation that you follow up with the doctor as soon as possible to confirm or to support your treatment methods or not. I can't support that. So that's coordinated of care that I've made a recommendation to go follow up with the pediatrician and that I come to the doctor with him.
Wonderful. Thank you so much. You have done a phenomenal job on this.
Thank you.
Great. And then Dr. Soul, I just unmuted you as well.
Great. Hey, so excellent job. Way to go. This is some tough stuff and can be really, really trying. And you've done just a marvelous job of working with this family and sounds like in a kind of ever-moving dynamic as well. So good job. So a couple of thoughts, I know, or a couple of questions. Is mom able to give this little guy much attention throughout the evening or the day? Because I mean, he's booked pretty solid, if I remember correctly from the case presentation form. Is he getting much one-on-one time with his mom?
As sad as it sounds, it was too much one-on-one with mom.
Okay.
And that's part of the problem. Mom, even when she went back to school to get her nursing degree, as we all know how demanding that is, she's now in clinicals.
Okay.
So she's there in the morning to get him dressed and prepared for ABA.
Yeah.
And she comes home about an hour after he gets out of school, about 4:30. So what we've now added to his picture schedule for the day, we added a picture of mom in the morning before ABA, and we added a picture of mom in the evening at 4:30, usually when he comes back from speech or he's come back from school or something, to let him know that mom's going to be here now and then she'll be here again.
Great. So that's great. Do you know if, so I definitely hear what you're saying as far as she's there in the morning to get him ready. And then now I think that's a great idea because I was going to ask you if he had a visual schedule. So check on that. That's great. But do you know if there's dedicated him time? So even if it's like 10 minutes, 15 minutes of not the baby, not the dad, not the grandparents, but him and his mom, who apparently have a pretty tight connection. Do you know if they're having any of that?
Saturday.
Only Saturday.
Saturday is their day. He absolutely loves to go to Target. So they go get pizza and they go to Target to get a toy and do all the errands, and it's just him and her.
Okay.
But even then, she still reports that those Saturdays, and if dad needs help or grandma needs help throughout the Sunday when she's usually studying, she will stop studying to help out then as well. I didn't try to completely eliminate mom's role, but it was like kind of twofold. Mom was doing absolutely everything from feeding, dressing, taking him to school, picking him up. She was doing bedtime routine. She was doing everything. So it's natural that he has this attachment to mom.
Oh, yeah.
Anybody else try to step in and do anything, it's a problem. So now mom has to stop what she's doing to go and help. And it's got to the point where even with her assistance, it's not helping. So we did recommend, and initially, no, mom was not taking the time on the weekends to just dedicate to him. She was like, well, I need to study. And I did bring her back to her attention that children with autism, they don't handle change well. And it was all of a sudden that you just left and went to school. And although you do come back home, he doesn't understand that transition of mom leaving and coming back. So I need for you to dedicate some more time than what you are to him so that he knows that you're still here, you're still mom, you're still caring. So she has agreed to make that Saturday all about him.
Okay. Great, thank you. The other thing I was wondering, I know you've talked about how he has a schedule for the day. Does he have a specific one for his bedtime routine?
No picture schedule, just the regular routine of come home from school about 3:30, 4 o'clock. He has a snack.
Uh-oh. Shireen, are you there?
Can you hear me?
Yeah, I can hear you now.
Okay. So gets home at 3:30. At 3:30, he'll have a snack. After snack, if dad's up to it, they'll go for a walk. By the time they come back from the walk, mom's home from school. They have dinner together. He gets his hour and a half, and then it's time for bed. It's time to start getting ready for bed. That's every day.
Okay. And then last question. So since they've started the melatonin, have they noticed any improvement?
No. That's why dad said he wanted to give him Benadryl.
Gotcha. I'm going to save my thoughts on that for the recommendation section. Don't let me forget, okay?
Okay.
Yeah.
I'm so looking forward to this recommendation section. You guys
Don't worry. And so do you by any chance know how much melatonin that dad has given him?
3.
Okay.
They recommend for children 1, but he's been giving them 3.
Okay. Hold on. I might have one more question. How's dad's stress level?
Extremely high.
Okay.
That's the reason why I have gotten dad to be more compliant, because he's actually expressed he's to the point, Shay, I really don't know what to do. I'm ready to give him Benadryl, make him go to sleep so that I can sleep.
Yeah. Okay. All right. Good. Thank you. Thanks. Excellent.
Excellent. Well, thank you so much, Shireen. At this part, we will then move into recommendations. And so we'll start actually with our audience participants, because as part of ECHO, it is our mission to be able to share knowledge within our network. So if anybody has recommendations within the audience that you would like to share at this time, please feel free to unmute yourself and share as well. Yes.
Is you ready to go? I don't want to interrupt anybody. All right. Nice job, Shireen. Definitely sounds complicated. As a mom myself, I can relate to, like, I'm present, but am I really present with my kids, you know? And moms are always multitasking and making things happen. So I thought Dr. Soul's question on that topic was a really good one, and it got me thinking. I just recently with a client had a lot of success. Mom was also very valuable to him, as all moms are, but he sat on her lap through all of therapy. It was really starting to interfere and kind of hinder his progress because he was so attached to her. Just recently on the visual schedule, similar to what you're doing right now, it sounds like with mom's picture on there, we have a token board now, and he's got a social story paired with it, so he kind of has a description of what we're expecting. But after he gets 5 tokens, he gets to go show it to mom and gets a 5-minute break with mom. And then I gave her a list of interactive play ideas so that those 5 minutes are really not divided, but really undivided attention to him. That's really interactive and playful, because they weren't getting a lot of that. She was studying, as well as this mom, studying while he was on his lap, or he'd be near her, but she'd be studying. So her attention was always divided. But we've been seeing a lot of great progress with that, and then we've been able to fade out these mom breaks. So now he has to earn 10 tokens, and then he can go bring the token board to mom, and he gets a 5-minute break still with her. And sometimes he opts out of the mom break, but we notice now that he's way more productive in sessions. So I was just going to share that little anecdote, and good luck.
Thanks.
Thank you, Sarah, as always, for your contributions. And do we have anybody else within our team that would like to share at this time?
Okay, 5 minutes. Oh, I got some goldfish. Want some goldfish?
Okay, perfect. Let me just Okay, great. Thank you for muting yourself again, Sarah. Okay, so then we will go ahead and then move on to recommendations from our panelists as well. And I see that Dr. Soul actually just turned off her video, so I was going to start backwards and move with her, but I don't. Okay.
Sorry.
So we're going to move backwards this time, but would you like to start off with your recommendations first?
Sure. Yeah, sorry. I had a patient phone call coming in, and so I was just trying to let them know what was going on. So anyway, yes. So a couple of thoughts about recommendations. I'm not sure how coherent they're going to all come out, so I'll try. But I think that exercise is a hugely important thing for children and an often completely undervalued piece for sleep. I've done a ton of work around sleep, both research and clinically, and have done some pretty intensive trials with kids. And I don't mean like drug trials. I mean like behavioral trials and trying different, quality improvement type things. And what we found was that kiddos who we tried the intervention of increasing exercise actually did have improvements in their sleep. So, I know you said when Dad's up for it, he'll take him on a walk, which I think is great. But if there's any way to make that a permanent fixture in the afternoon or whatever, I think that will be helpful. Or I don't know how active this kiddo is, but those little trampoline thingies, if he likes to jump, that's a good strategy to wear him out. Those are some ideas. One thing that I'm hearing as I hear you talk about this family and as I hear the presentation is that I hear a really overwhelmed family. As a physician, I can tell you that the job is insanely stressful. And so even though he's only quote unquote working 3 days a week, those 3 days are probably pretty hellacious. With in-laws or grandparents in the home, whether they're in-laws or not, I don't know for sure, but it's a stressful environment. And so I think that kind of resetting and helping the family recognize that, hey, actually the sleep is everybody's stressed. And when you're stressed, this little guy feels that also. And I loved what others have talked about as far as, being present, not being present. I love that Mom's giving him her Saturdays, but that's like me having to wait until, one particular day of the week to get a high from my husband, and that wouldn't work. And so just thinking about how can she build in, and maybe you frame it as like a pilot, again, so I do a lot of quality improvement, so we're always doing these things called small tests of change, which is a lot of what you guys do too. But basically, say, what would it look like if for this week we tried just 10 minutes, set the timer, hardcore love fest between you and this little guy, whether it's doing his favorite activity or maybe it's taking a walk around the block or whatever, where just the two of them. I can't help but think that some of his sleep stuff is a result of kind of discombobulation within the house and just not quite, he seems discontent, not unhappy, just not settled either. And so I just wonder if grounding him with a little bit of extra time with his mom would be helpful. And then if that doesn't work, which it may not, one of the things to think about, I would set up a pretty structured bedtime visual schedule for him. So, it sounds like you have a great visual schedule, and I don't know for sure how detailed it gets, but around bedtime, I would do some specifics, so brush teeth, and again, I don't know for sure how specific you already have it. You may already have all this, but get it pretty specific so he knows what's coming next. And I would make sure it includes a kiss from his mom or a kiss from his, or whatever. I'm saying a kiss. That may not be his preference, but whatever, something where he knows the day is closing out might be helpful for him. I thought about for a little bit whether he would be a kiddo that a bedtime pass would work for, but I don't think so based on the verbal ability, so I don't think that's going to cut. Thinking about, along those same lines, there's a really cool program that's had some decent evidence behind it. It's called Read, Play, Hug, or Hug, Read, Play. I can't remember which way they go. But evidence is actually shown, this makes me sad, but evidence has actually shown that if you spend 9 minutes a day, that 9 minutes a day is all that a kid needs, which again, I'm like, but 9 minutes a day, 3 minutes with affection, 3 minutes reading, and 3 minutes playing is all a kid actually needs, like the bare minimum. Okay, I added that, I don't know. But 9 minutes doesn't seem like long enough. But the actual evidence behind it, that 9 minutes can significantly impact a child's social emotional well-being. And so I wonder if framing that for her might not be helpful. Like, hey, let's see if we can't do something, or, you know, something for 10 minutes or 9 minutes or whatever. I know as a mom, when I first heard that, I have to tell you that it kind of eased my guilt a little bit because I suffer from serious mom guilt. You know, when I heard that, I was like, 9 minutes, are you sure? But it did make me feel a little better. And so I was able to kind of, for myself as a busy professional, as this mom is with school and this dad is with work, maybe it's something that could kind of help them do that. So then a comment about the medicines. So I use melatonin all the time. And I don't think that there's anything wrong with melatonin. I think the most important thing for the family to know is that it's an herbal supplement, which means there's no evidence to say that it works and there's no evidence to say that it doesn't. So in other words, it's not FDA approved. Okay, so I don't have safety trials. I don't have outcome studies. There are some studies, by the way, but they're not. I wouldn't hold them into the highest degree of esteem. But that being said, it is used regularly for kids with sleep problems. I have seen it work quite nicely. I generally have families not go above 3 without talking to, well, they're already talking to me, but without them calling me back. And so that's something to kind of think about. As far as Benadryl goes, I would really encourage the dad not to go that route. So kids, there's something called a paradoxical effect, which is where it basically hypes you up. And kids with autism are more prone to that paradoxical effect than kids without autism, that is. So, I mean, it's not going to hurt him likely, but at the same time, it could cause like an even worse outcome. So I would probably steer clear of that. But one thing I do want to recommend, or one thing I wanted to say, is that what that tells me is that dad has gotten to a level of, I mean, is getting close to desperate, it sounds like, if he's not already there. And one thing I can tell you about physicians, we're fixers. We want to fix everything. And so especially an emergency room doctor. So if you're thinking about what does it take to be an emergency room doctor, that's called quick fixes and high drama. And so he is high stress, quick fixer. So we have to know that, because that puts this little guy at more risk for a couple of things. Having unnecessary medical prescriptions, not saying that they might not be necessary at some point, but we just need to be mindful of that. I love that he's asked you to come to the doctor. That's amazing. But anyway, just knowing the context of dad's thinking process, it's telling me that he's getting desperate and he's going to pull out the stops to fix it. Hopefully he won't go to what I've seen many physician parents do, which is like, I'm going to fix it. And I'm going to prescribe him this and this and this, or I'm going to demand that this and this and this get fixed now. But just for your insight, that is something I think is important for you to keep in mind and to consider as you're making this plan with the family.
Okay.
Okay. Sorry, I could talk forever. If you have noticed.
Thank you. Thank you very much, Dr. Stoll. I really appreciate it. And since we're going backwards, would you like to go?
Sure. Hi, Shireen. It's Kathleen again. I just had one very brief comment. I'm sure you're already doing a wonderful job, but I thought I would mention it. Is you mentioned that dad places blame on mom for the sleeping together and the result of that. And so just wanting to make sure that we're also praising mom for the things that she's doing well and for being so flexible and willing to implement so many things. I think the family's response is always impressive to me, and they're moving bookcases out of the room and making all these adjustments, and so just making sure we're recognizing that along with the recommendations for additional adjustments.
You hit me again. We're gonna have some problems.
Great, thank you. And let's I'm sorry, I'm looking for you, but Dr. Goldsmith, let me unmute you.
Okay. Look, I find story.
Oh, I think maybe I did not unmute you. I'm sorry. Okay. There we go.
There we go. Hi.
Hi.
I honestly don't have a ton to add. I think Dr. Zoll had recommendations, and mine are perfectly in line. I mean, I think that it's sounds like all the basics there, but going to tighten things up and sort of making, although you're kind of flexibility in there to some degree at nighttime routine and create a specific time, right? That this is always going to start at PM and each activity they're in sort of a transition point is important. For a lot of kids, routines can be 30 minutes, and that's it's reasonable. But for some kids who have a need to have a longer night routine, it's okay. You can always sort of hold on that as this kid experiences success. And so just think about the overall duration of that nighttime routine and where you kind of hit the sweet spot for those. I also agree with sort of the visual nighttime routine. I think that would be huge for him. And I think if you build out the structure of the nighttime routine, I think there's some ability with regards to whether dad are supporting that nighttime routine, ensuring that he understands when are mom's nights and when are dad's nights. If dad is sort of on-call schedule and his nights are indeed predictable, mom is going to have to step in when dad's not there. That should just be part of their sort of expectation across days. I do think there's a lot of data to support sleep restriction for kiddos who present with these types of issues. And there's a host of studies by Durand and others that indicate that's a good idea. And so I very much like the direction you're going there. I think that it does take some decision making to, again, kind of hit the right point at which you start that time routine and ultimately have him go to sleep, and then his wake up time should ideally. And so again, I think if you can get that sleep diary data to give you more insight into the shift across days, it would be a cool way to inform decision there. It may be that where you're starting feels really late. I think you start something versus 7 something. It may need to be even later, and then work your way earlier, more age appropriate at times. And last but not least, what you're doing with regards to, or I guess two more things. You're doing with regards to trying to ramp up the physical activity on weekends, I think is a great idea, giving some more flexibility. And just make sure the parents hear within what you're saying about shifting activities from daytime and weekend, at the nighttime again, remain the same. That to the degree possible, let's get that nighttime routine consistent across 7 days of the week. And I think you're probably doing that. Just want to make sure the messaging is pretty clear for parents. The last thing is, I think that, if you haven't already, give the parents some even more clear guidance for exactly what to do step by step for if he does wake up at 2:30 in the morning. And I think, again, you've done that, right? Use the monitor, make sure he's safe, trying to go in there. But if push comes to shove and parents do have to intervene, what that intervention looks like, how should you direct him, what should they say, what's the expectation? But, again, I think none of that probably sounds like a big surprise, and you probably sort of started on the path of all things, and it's now just about refining and beginning to get it just right. But a great job today.
Wait, Corbin. Thank you so much.
Great. Thank you, Dr. Goldsmith. And Zoe, let me go ahead and unmute you.
Great. I mean, a lot of the things have been touched on by other participants and hub members. I have a couple of things, and first of all, I love seeing your little boy in the background. I relate to that. I have little ones too, so I just think that's wonderful, and you are doing an amazing job of staying focused. So just a couple of thoughts, and again, I think that maybe if you haven't already, maybe doing an FBA, the functional behavioral assessment, just to kind of see like what are the potential, if there are behavioral reasons that he's doing this, kind of what those might be if you haven't done that already. And then I know that for me, I obviously have dealt with this issue, but also did it with my own child, is to try kind of one thing at a time. That one of the things that was hard for me is it was kind of all over the map, and I couldn't figure out, my child was all over the map, I was all over the map, I was exhausted. So it was kind of hard to stay focused on, okay, I'm trying this now, and is this working or isn't it? I've tried it for enough time. I haven't, as a parent, sort of shifted things so much that I can't really tell whether it's working or not. And so those are two sort of general recommendations. One is for the parents too, and I don't know if the family can work this out, but one of the things that has been helpful for families that I worked with is sort of tag teaming. And it sounds like they're doing a bit of that already in terms of putting this little guy to sleep, but also tag teaming in terms of them getting a good night's sleep. So deciding who is it that's going to get up, how the other parent gets as much as possible a good night's sleep, so everybody isn't, again, running already in a stressed environment, but now sleep deprived. That I have found that can be really helpful, both in terms of the child, because the parent is more rested, but also just in terms of the general functioning of the family. I had a thought about the fact, two things, just in terms of that nightly routine. One is sometimes bath can be stimulating versus calming, and so that was just a thought to kind of look at that. I guess the same thing is true in terms of the iPad and the television, that for a lot of kids, that is not conducive to getting their body and mind to start slowing down and getting into a place to fall asleep. And although it sounds like there's issues with falling asleep and then staying asleep, and those might be separate. So the TV and the iPad. And the other thing was eating, that if he's having a cookie and milk or fishies, all of those are quick burn, right? So his body is going to burn through those really fast. So I wonder, like, is he waking up hungry? So anyway, those are just things. And again, I think there are more questions or maybe areas that maybe you've already looked at, but maybe looking at looking at it again as kind of one of the variables that may be affecting. And then the last thing is just naps during the day. Like, I wondered, is he napping? That really, I mean, he is getting so little sleep. And I have just found that in my work and also with my kids, it's that sleep begets sleep. Lack of sleep sort of is self-perpetuating. So anyway, Shireen, you're doing a fabulous job. And this family is very lucky to have your support. So those are just some recommendations. And again, you may have tried all of those already. So I hope that's helpful. And again, thanks for presenting this. I think it's been super informative to all of us.
Mm-hmm.
Absolutely. I couldn't agree more. Thank you for your contribution, Zoe. And I would like to also piggyback on the fact that I love seeing your child in the background too, because I think that also highlights the benefits of Echo and the access that this creates, because you can be at home and still be able to consult on a case and receive recommendations and in its real world. So we love that. And so I wanted to add a couple things. I see also we have somebody that raised their hand too, so I'd love for Lisa to be able to share her contribution as well. I would say that one of the things that Zoe brought up that I also was thinking about too is really also trying to look at some of the behaviors and what is maintaining it. It seems like maybe we talked a little bit about at night when he's having difficulty falling asleep. Is it related to, is it social positive? Is it access to mom's attention? Or is it more automatic, especially in the middle of the night when he's getting up and he's reading and he seems to be kind of roaming around, and maybe he's not interacting with others, but really trying to identify and tease that apart would move into kind of some of those recommendations that Dr. Goldsmith was providing when we're looking at trying to fine-tune a lot of the pieces that you already have in place. So that might be helpful, and it might be a little different, for both the nighttime awakening versus when he's going to bed in the evening. Something else that Dr. Goldsmith brought up that I thought was a really good consideration is what is maybe occurring in the middle of the night with the sibling who's also young, and if there's other phone calls or things that might be going on. And so thinking about maybe the adding some type of other discriminative stimuli to occasion going to sleep, but that also could help with that background noise. So either a sound machine, there's a lot of apps that you can get on phones. That actually might be problematic though, because then he might try to get on the phone, but maybe a sound machine or something of that nature, so that when he goes to sleep, the environment is the same as when he wakes up in the middle of the night. Because if it's different when he goes to sleep than when he wakes up, that also might be not helping, at least for him being able to go back to sleep. The family sounds amazing. The fact that they are, it is everything that families go through to help their child and to be moving the things out of the room. One thing that wasn't clear to me that I just wanted to bring up as a thought was that he is engaging in some behaviors that are disruptive when he's not going back to sleep, and it might be getting books, but then it seems like it might be leading to other things such as climbing on shelves and leaving the room, his bedroom, and roaming through the house is what I understood. So you might want to consider what are some lower level tasks, engagement tasks that maybe could be nearby, so it's not a safety concern, so that if the parents are watching him through the screen, he can engage in some of those tasks without leaving the room, because that also might be more of a safety concern if he's roaming throughout the entire house versus if we could keep him within his room. Also might help the parents too with their stress and being able to feel more comfortable and knowing that he's safe if he is waking in the middle of the night. But it was also a little unclear too, because it seems like mom is sometimes sleeping the whole night with him, and then sometimes she's getting up and leaving. So I also think that contributes to some of what Dr. Goldsmith was bringing up too, with the procedural integrity and being able to really identify what is occurring in the middle of the night during this stressful time, and then what they're doing just to get through the night. And so it seems like it might be varying a little bit, and that might be something worthwhile when you're discussing this with your team to continue to look at too, because I think that probably is one of the most stressful pieces right now is that nighttime awakening for them as well. So I know that we have Lisa, who raised her hand. Let me unmute you as well. And
awesome. Yeah. Hi guys, thanks for letting me come on board. I'm in Albuquerque, New Mexico, and I don't have a kiddo with autism, but I have a sensory processing disorder, and my two youngest children do. And pretty much what you guys were talking about, we can't sleep without a fan, none of us, myself or my kiddos. White noise machines are actually pretty painful for us, and so what I recommend, and even some fans can be very painful, what I recommend and what we've had the most success with is like a Lasco brand or Vernado brand fans, especially for some reason with the remote control. They have less of a likelihood to have some sort of like weird sound in them, and those help a lot, so that we actually even travel to hotels with small Vernado fans. It's something that our brains are just used to, that when we find that in a room, we go to sleep with it. And so we're all people that have sleep problems because of that sound. So it sounds like everybody's on that track. And then also we do better on the cooler side because we tend to have to sleep with weighted blankets and things like that. So the fan, as opposed to a white noise machine, kind of pulls double duty in that way. So that might be something to consider for this family too, and especially as the summer months are heading in.
Great. Thank you so much, Lisa. I think it's nice to think about the different types of, because we say white noise, but we don't think about the different types of things that we can use for noise in that background. And I know that I personally listen to ocean waves or rain. And so, but just knowing that too, to be able to look at the different types of background noise that might be successful, and preferences as well, taking preferences into consideration. for each individual. So I think that that was great to hear as well. And then, you know, I'm so sorry, I forgot there's one other thing that I wanted to ask as well, or just throw out there as a thought, because he is receiving one-on-one ABA therapy. Sometimes it might be helpful too, if the family is feeling really overwhelmed, to shift the session times into the evening to help them get on track with the, and you might have already done this, but to help them get on track with the bedtime routine. Also, it would give maybe you a little bit more perspective on whether there's some deviations that they don't even realize maybe that they might be providing during that time. So if that's something that is possible, given the scheduling and different logistics, that might be something too to consider, just to kind of help jumpstart and provide the family with a little bit more support too, since they seem to be a little stressed at this point in time as well. And Shireen, this is your first ECHO clinic, so we will actually be emailing you all of the recommendations following the clinic, so you do not need to worry about getting everything. I know that you had asked about one of the resources Dr. Soul had recommended too, so we'll include that in there, as well as just some other additional resources that you might find useful to reference. And we really appreciate everything that, all the information that you provided, and just joining us today. You did a wonderful job, and we look forward to hopefully having you back for a follow-up.
Thank you so much. I appreciate it. And definitely everything that you said is so beneficial. Actually, it's about the nighttime changing. I've actually offered to come to their house in the middle of the night and stay and get real data, because I need to see for myself. Yes, I trust Parent Report, but I'm willing to go at 7:30 and sit and observe the bedtime routine all the way to the morning, just to get a real clear idea of what's really going on. But thank you so much, you guys.
Wonderful. Well, thank you. And thank you to everybody who contributed. I appreciate the contributions from all of the participants. It was wonderful.